In ophthalmology, as in all clinical disciplines, diagnosis is the basis of effective case management. Ocular conditions can sometimes seem a daunting diagnostic prospect. They may have a bizarre, confusing appearance or present as a potential emergency situation. Conversely, things may not be as straightforward as they first appear. The eye and its surrounding structures exist in balance. Disruption of this balance can have flow-on effects, and secondary signs may be more obvious than the primary lesion. Also, the eye is not an isolated system. Ocular changes can occur in a number of systemic disease states, including metabolic disease, infection, and coagulopathy. All of these factors need to be taken into account in performing an ophthalmic examination.
The key to an ophthalmic exam is to work through in a methodical manner and build a case, take all the information that's presented to you before you make a diagnosis. So you have a routine that you're comfortable with and will make sure that you don't miss things. You don't want to be in a situation whereby you think you've got an answer and you haven't finished the exam. You may miss the point that tells you what's going on.
Both eyes should always be examined and compared.
Eyes are great because most animals have two of them, and you can use the good one to compare to the bad one and vice versa. Is what you're seeing in one eye normal or abnormal? Look at the other eye. If you see, for example, a distichiasis hair in one eye and you see a distichiasis hair in the other eye, but only one eye is painful, you don't assume that the distichiasis hair is necessarily the cause. There may be something new.
Routinely examining both eyes also increases familiarity with the range of normal ocular appearance.
It's very important to recognise normal. The more cases you look at, the more normals you look at, the more likely an abnormal is going to stand out and reveal itself. Even if you don't necessarily know what the problem is, being able to recognise that as abnormal is a key feature.
Equipment available for ophthalmic examination ranges from the comparatively simple to the specialised and very costly. Specialised procedures are necessary in some cases for establishing a diagnosis. However, much can be achieved in general practice by careful use of a relatively basic set of equipment.
In terms of equipment, I like to work from the front of the eye to the back of the eye, and to start off with you need some sort of light source, and that can take the shape of a pen torch or a transilluminator.
The transilluminator is an attachment that fits the ophthalmoscope handle. It is generally preferable to a pen torch as it produces a brighter, more focal beam, giving better illumination with less scattering of light.
Other possible equipment you would consider if you've got an abnormality that you want to have a closer look at, particularly if it is on the external surface or involving the cornea or the eyelids, then some sort of magnification is handy. For example, the loupes we've got here give you about 2.5 times. You can get them up to 4.5 times. They're quite expensive, but if you've got an interest in the field, then I would recommend looking at getting some form of magnification to assist. Working deeper into the eye, we start to use the ophthalmoscope to assess the fundus, which includes the optic nerve head, the retinal vessels, the tapetum, the non-tapetum. It's very important to have equipment that will allow you to look through the lens. You will not achieve that with a simple pen torch.
The main forms of ophthalmoscopy used in the veterinary field are direct ophthalmoscopy and indirect ophthalmoscopy. Each has certain advantages, and it's ideal to have access to both. If there is reason to suspect that the tear film is inadequate, Schirmer tear test strips are useful for assessing tear production.
If you're worried that there's irregularity in the precorneal tear film, or if there's an excessive mucopurulent discharge, then you certainly should be doing a Schirmer tear test.
Local anaesthetic drops have various applications, including examination of a painful eye.
Particularly if there's a nasty ulcer, to facilitate examination, using a local anaesthetic will allow you to open the lids and make the animal more comfortable, to hopefully get the third eyelid out of the way and let you see what's going on.
To facilitate ophthalmoscopy, it is often necessary to dilate the pupil using an appropriate mydriatic, such as tropicamide.
Tropicamide is an atropine-like agent and is short-acting, so it will dilate the pupil, but it will only last for 1 or a couple of hours, as opposed to atropine, which particularly in cats can last up to a week in a normal eye. In fact, I've had animals referred because their pupils weren't responding a week after having atropine. The corneal integrity can be assessed by the use of fluorescein, and I would advise using fluorescein in just about every case that presents, particularly if there's any pain. To assess the fluorescein, it's very important to have some sort of blue light source. This will help amplify the return from the fluorescein stain. Many people in practice will have access to a Woods lamp, but that's actually an ultraviolet light and is probably not ideal for the health of the cornea or the eye.
Fluorescein can also be used to assess nasolacrimal patency. While this technique has some limitations, it can help to determine if further workup is needed.
If you suspect an imperforate nasolacrimal punctum or poor drainage, then flushing the nasolacrimal ducts would be the next course of action, and you would need local anaesthetic for that and a nasolacrimal cannula. Further ancillary tests, again, if you've got pain or concern of vision or abnormalities with the globe itself, you might be concerned about pressure, and I think it's important to have some sort of means of measuring pressure, and I recommend the Schiot's tonometer is a very good instrument for private practice because it is relatively cheap and affordable and will give you an all or nothing. It is not perhaps as precise as some of the other equipment available, but it will be able to tell you whether an eye is hard or whether an eye is soft compared to the contralateral eye. If you're feeling like spending more money or you've got a particular interest in ophthalmology, then something like the toner pen is an excellent device for everyday use.
Signalment and history are extremely important in ophthalmic examination.
And have you had Shelley since she was a kitten?
Yep.
And she's now 8 years old?
Hi.
Many ocular diseases exhibit age and breed predispositions.
She's been a healthy
Really
cat.
healthy, yeah.
Good. And
Also, the animal's general health status is useful to check for underlying systemic disease processes.
toilet's okay?
Ocular pain and changes in vision can be difficult for owners to assess.
Have you noticed any signs of pain, any irritation? Has she been winking the eye or holding it closed?
No, nothing.
Okay, and no discharge?
Information about the animal's behaviour and demeanour can be helpful.
She's just not herself, and she doesn't go outside as much, and she won't jump up onto my knee, and she's just, I don't know, I think she's just really quiet.
Over what sort of period has that been?
About a month.
And has it been quite a sharp change or has it been a gradual change?
Gradual.
It's important to start the physical examination by observing the animal from a distance. This is useful for assessing pain, as clinical signs of pain may be reduced when the animal is being handled. Evidence of pain includes an increased blink rate or winking, blepharospasm or spasm of the muscles of the eyelid, and excessive lacrimation, which may present as a tear stain on the hair. There may also be evidence of photophobia. Third eyelid protrusion can also be a sign of pain and discomfort. Ocular pain usually indicates involvement of structures in the anterior segment of the eye. These include the eyelids, the conjunctiva, and the cornea, and within the eye, the anterior chamber, iris, ciliary body, and the lens. Note that topical anaesthesia will only relieve pain associated with the surface of the eye. If pain persists, the source is more likely to be intraocular. Pain associated with glaucoma can be difficult to interpret. Particularly with primary glaucoma, acute signs of pain often give way to more subtle changes in demeanour, and even these may be masked when the animal is distracted. In cats, glaucoma is almost always secondary to another disease process. Its onset is often insidious, with little clinical evidence of pain. Before beginning to handle the animal, the orbits should be assessed, checking for overall symmetry, the size and position of the globes, and the resting position of the eyelids. Abnormal eyelid position can be a primary finding, for example as part of Horner's syndrome. It can also be secondary to changes in globe size and position. In this case, a cranial nerve deficit resulted in enophthalmos, where the position of the globe is abnormally deep within the orbit. Globe displacement is difficult to appreciate from this angle, but becomes much more obvious when looking from above. Widening of the palpebral opening is a consistent feature of buphthalmos, or enlargement of the globe. This is almost always caused by chronic glaucoma, so there are usually associated signs of disease, in this case corneal edema and marked pupillary dilation. A widened palpebral fissure can also result from exophthalmos, or forward displacement of the globe. Here, extraocular polymyositis resulted in bilateral exophthalmos with increased scleral show. Again, the view from above is useful. In this case, a retrobulbar mass resulted in unilateral exophthalmos with strabismus, or globe deviation. Protrusion of the third eyelid was a consequence of altered globe position. Strabismus can have a number of causes. In this case, it was a developmental abnormality. Note that bilateral strabismus is considered normal in some breeds. To examine the eyes more closely, begin with minimal handling by observing the resting size of the pupils. Be alert for obvious meiosis or mydriasis. Unilateral changes appear as unequal pupil size or anisocoria. Note also the presence of any ocular discharge. It's not unusual to find a small amount of mucoid discharge at the medial canthus, particularly in dogs with deep orbits. Abnormal findings include purulent material, crusting, and bleeding. Note also any tear overflow. In a painful eye, this is likely to be caused by excessive lacrimation. In the absence of pain, It suggests abnormal tear drainage. The surface of the eye should now be examined in detail, beginning with the upper and lower eyelids. The eyelids should then be everted to expose the eyelid margin. This reveals the openings of the meibomian glands and the lacrimal puncta. In this case, inspissated meibomian glands are visible under the upper eyelid. Eversion of the eyelids also facilitates examination of both the palpebral conjunctiva, on the inner surface of the eyelids, and the bulbar conjunctiva, which covers the visible sclera. The third eyelid can be examined by gently depressing the globe through the upper eyelid. Note that the conjunctiva also covers the inner and outer surfaces of the third eyelid. The normal conjunctiva exhibits regional variation in colour, which needs to be distinguished from inflammation. There may also be normal pigmentation. The underlying sclera is usually white. The appearance of the cornea should also be noted at this stage, though more detailed examination is performed later using a light source.
Squidgy.
In examining the eyelids, it is important to be alert for anatomical defects, particularly when there is ocular discomfort. In this case, there is bilateral upper eyelid agenesis, a developmental condition seen mainly in cats. There is partial absence of the eyelid margin, resulting in direct contact between the facial hair and the cornea. More commonly seen in dogs are abnormalities of eyelid position, such as entropion, and disorders of the eyelashes or cilia. Trichiasis involves the misdirection of cilia and sometimes facial hair towards the cornea. Dystichiasis refers to the emergence of cilia from abnormal locations along the eyelid margin. Ectopic cilia are abnormally positioned lashes that emerge through the palpebral conjunctiva. While these anatomical abnormalities can all cause ocular irritation, caution is needed in interpreting their significance. In this animal, dystichiasis hairs and an ectopic cilium were present in the same eye. There was corneal ulceration, but only in a discrete area that was consistent with trauma from the ectopic cilium. Thus, treatment for dystichiasis would not have resolved the problem. Other lesions of the eyelids include meibomian gland inflammation, which needs to be distinguished from neoplasia. Eyelid tumours are not uncommon and can present as a discrete mass or as an invasive lesion. Depending on their size and location, they may cause ocular discomfort. Inflammation and traumatic injury may also be encountered. Lesions specific to the third eyelid include scrolling of the cartilage and prolapse of the gland of the third eyelid, or cherry eye. In the conjunctiva, inflammatory changes are the most commonly encountered abnormalities. Acute conjunctivitis typically involves hyperemia, which appears as redness. This is often accompanied by chemosis or conjunctival edema. Conjunctivitis is often a clinical sign of other disease processes. In this case, use of a local anaesthetic helped to reveal an underlying corneal ulcer, which was confirmed by fluorescein testing. Conjunctivitis can also be a primary disease condition. Feline herpes virus infection is a common cause of severe conjunctivitis in cats. Feline herpes and other causes of severe conjunctivitis can result in loss of conjunctival epithelium. This can lead to symblephron, a condition characterized by adhesions between the conjunctival surfaces. If conjunctivitis becomes chronic, follicular hypertrophy may be evident. This is a non-specific finding resulting from stimulation of lymphoid tissue within the conjunctiva. It's important to recognize that a red eye can also result from changes in the tissues underneath the conjunctiva. Here there is episcleritis, or inflammation of the connective tissue that lies between the conjunctiva and the sclera. In this case, there is congestion of the episcleral vessels. This is a common feature of glaucoma, but can also occur in other diseases, including uveitis. If examination thus far has revealed evidence of discomfort, conjunctivitis, or mucopurulent discharge, the possibility of a tear film problem should be considered.
It's very important to detect tear film problems early, because the longer the problem is ongoing, the harder it is to get back normal function, because a percentage of the tear-producing cells will be permanently dead and they cannot be replaced.
The Schirmer tear test is a useful means of measuring aqueous tear production.
This is crucial in cases where conjunctivitis is recurrent. If you didn't do it the first time, then you must do it the second time. You need to make sure that the tear film is intact and healthy, because it's so crucial for the health of the cornea.
The Schirmer tear test strip should be inserted in the lateral half of the lower conjunctival sac. The strip should be in contact with the cornea, as this provides the stimulus for tear production. The strip is left in place for 60 seconds. Both eyes should always be tested. A reading of 15 millimeters or greater in 60 seconds is consistent with normal tear production. A reading of less than 15 millimeters in 60 seconds is suspicious, particularly if there are clinical signs of disease. Note that the Schirmer tear test measures aqueous tear production, which represents only part of the normal tear film. The tear film has three main components. The outer lipid component is supplied mainly by the meibomian glands in the eyelids. The aqueous portion is produced by the lacrimal gland, accessory lacrimal glands, and the gland of the third eyelid. The inner mucin component originates from the epithelial cells of the conjunctiva. A deficiency of the non-aqueous layers can result in clinical evidence of dry eye, often with corneal ulceration, despite a normal Schirmer tear test result. Schirmer tear test results should also be viewed with caution in assessing tear film problems in cats.
In cats, the Schirmer tear test is much less reliable and more difficult to interpret. I've seen normal eyes, normal corneal health and comfort, and a tear production of 5. If one eye was uncomfortable and the other eye was comfortable and they both have the same tear reading, I don't think you can attribute it to a dry eye problem necessarily.
The ocular touch reflexes are used to assess the innervation of the eyelids and the globes. The palpebral reflex is tested by touching the skin of the eyelids. The normal response is a blink. The afferent arm of the palpebral reflex is cranial nerve 5, the trigeminal nerve. The efferent arm is cranial nerve 7, the facial nerve. This supplies the orbicularis oculi muscle, which is responsible for eyelid closure. The corneal reflex is tested by gently touching the surface of the cornea with cotton wool. Again, the normal response is a blink. As for the palpebral reflex, the sensory arm of the corneal reflex is the trigeminal nerve. The efferent pathway has two components. The facial nerve is responsible for eyelid closure. In addition, there is activation of the abducens nerve, which stimulates the retractor bulbi muscle, resulting in globe retraction. Retraction of the globe into the orbit causes the third eyelid to sweep across the eye. This is usually not visible because the animal blinks. In this dog, idiopathic facial nerve paralysis prevents the normal blink response, but corneal sensation remains intact. Normal vision relies firstly on the transparency of the ocular media so that light can be focused onto the retina. Vision also depends on the functional integrity of the retina, the optic nerve, and various parts of the brain. Lesions anywhere in this pathway can result in a visual deficit. Abnormal vision is not always obvious, so establishing an animal's visual status should be part of routine examination.
Vision testing in animals, by its nature, is going to have a degree of subjectivity. It's not possible to ask them to read a wall chart. There are various ways of testing vision in animals, but it's important to remember that there is individual variation from animal to animal, and this is the case particularly in cats. They will often not menace very well. They just can't be bothered playing the game. Doesn't mean they can't see.
The menace response is tested by directing a threatening gesture towards the eye while keeping the other eye covered. Care should be taken not to touch the eye or create excessive air movement. The normal response is a blink. The menace response is not a reflex. Rather, it's a learned response that involves the optic nerve, input from the brain, and ultimately the facial nerve. As it is not a reflex, some animals can be quite stoic. Sometimes alternating the menace test with the palpebral reflex can produce a more obvious menace response. Alternating these tests can also help to interpret an abnormality. In this dog, the menace response is absent on both sides. However, the palpebral response is intact, ruling out a facial nerve deficit. Visual tracking can be tested by attracting an animal's attention to a cotton ball and then dropping it in the animal's field of vision. Cats can be uncooperative, but it is still worth checking for a positive response. A beam of light moved across an examination table will often elicit a response from sighted animals, especially the younger playful ones. However, this can still be inconsistent as some animals are easily distracted. Animals with loss of vision often have difficulty walking down stairs.
Pick up my visitor ears. Good job. Good job.
Climbing stairs is generally easier as it requires less visual input. While stairs can't always be accessed during an ophthalmic examination, it can be useful to ask the owner if they have noticed any such problems. Note also, though, that animals with visual deficits can become extremely well adapted to their environment. This 7-year-old Border Collie is totally blind as a consequence of primary glaucoma that affected first the right eye and shortly thereafter the left. The right eye was removed, while the left was fitted with a prosthesis. On his regular walking track, the dog shows remarkably little hesitation, even on challenging terrain. Vision loss becomes more obvious when the dog encounters an unfamiliar obstacle.
Oh.
In fact, an obstacle course, or maze, is another means of testing vision in dogs. The course should be set up in a confined space in a way that forces the dog to change direction. A dog with normal vision typically negotiates the course with ease, even under dim lighting conditions. If vision is abnormal, the dog is more hesitant and may bump into the obstacles. This dog has even greater difficulty under dim light. This so-called night blindness is a characteristic finding in progressive retinal atrophy. Note that if a unilateral deficit is suspected, the normal eye should be covered when the maze test is performed.
Good girl. Come on. Come on. Come on, Sally. Come on. Come on. Good girl. Good girl. Come here. Good girl.
Retropulsion is an examination technique in which the globes are depressed through the upper eyelids using the fingers or thumbs. The globes should move easily and painlessly backwards into the orbit.
Retropulsion is an underutilized technique. It can give you information about the orbit, and the orbit can be a difficult area to work with because you can't see it directly, and it often needs other imaging techniques such as ultrasound or MRI. Where retropulsion is beneficial is if there is a mass, for example, behind the globe, you will not be able to depress the globe easily on that side, whereas on the other side it will go nice and easily. Retropulsion can be difficult to interpret in brachycephalic dogs and cats because they have shallower orbits, and therefore the amount of room for the globe to manoeuvre is limited, and therefore you're looking for subtle variations between the two sides.
To examine the eye with a light source, the room lights should be lowered or turned off. Begin by re-examining the superficial ocular structures. Some lesions may be more obvious under illumination. The cornea should now be thoroughly inspected. In examining the cornea, it is important to understand the factors that determine its normal appearance. The cornea consists of several layers, including the epithelium, the stroma, Descemet's membrane, and the endothelium. The transparency of the cornea depends on the absence of corneal blood vessels, the lamellar structure of the stroma, and its state of relative dehydration, which is maintained by both the epithelium and endothelium. These characteristics can be compromised by a range of insults, including external trauma, extension of disease from adjacent tissues, intraocular disease, and primary corneal disorders. Clinically, corneal disease can manifest in different ways. These include edema, vascularization, pigmentation, cellular infiltration, lipid deposition, and scarring. Corneal edema may be diffuse, as in the classic steamy blue eye, or localized to a particular area, such as the tissue surrounding a corneal ulcer. Corneal vascularization can be superficial or deep. Superficial corneal vessels are bright red and branching and cross the limbus from the conjunctiva. Deep corneal vessels are straighter and are seen to emerge from under the limbus. In dogs, corneal pigmentation is generally a response to chronic irritation or mechanical trauma. It is usually restricted to the corneal epithelium. In cats, pigmentation occurs as a condition known as corneal sequestrum. This is the result of epithelial and stromal necrosis, with subsequent deposition of pigment from the tear film. Infiltration of the cornea by inflammatory cells can be associated with stromal lysis and infection. It is also a feature of eosinophilic keratoconjunctivitis in cats and chronic superficial keratoconjunctivitis, or pannus, in dogs. Corneal lipid deposition is more common in dogs than in cats. It can take the form of corneal lipid dystrophy, a primary corneal abnormality that is usually bilateral, or lipid keratopathy, where lipid is deposited as a result of an ocular or systemic disease process. Lipid keratopathy is typically accompanied by corneal vascularization. Healing of damaged corneal stroma frequently results in scarring. Without the aid of fluorescein, scarring can be difficult to distinguish from corneal ulceration. Fluorescein testing is essential in all cases of corneal disease to establish whether ulceration is present. This is best done later in the examination as the dye interferes with other procedures. In the meantime, it is crucial to be vigilant for clinical findings that might help to identify the underlying disease process. Here, for example, chronic corneal changes were attributed to a mass in the palpebral conjunctiva. In this animal, the history suggested traumatic injury, but the eye was unresponsive to treatment. The cause was identified as a foreign body that penetrated the cornea and settled in the anterior chamber. Corneal edema resulted from ongoing intraocular trauma and inflammation. In this case, diffuse corneal edema was caused by endothelial damage associated with acute glaucoma. If glaucoma becomes chronic, globe enlargement can lead to corneal exposure, resulting in epithelial damage. In this case, a brain tumour with facial nerve involvement prevented eyelid closure. This type of lesion does not necessarily result in significant corneal damage, because the blinking stimulus can still bring about globe retraction with spreading of the tear film by the third eyelid. In this brachycephalic breed, however, prominent globe position exacerbated corneal exposure and a corneal sequestrum resulted. This is in contrast to a trigeminal nerve deficit, where loss of corneal sensation eliminates the urge to blink. Severe corneal damage ensues. When examining the inside of the eye, it is very important to appreciate the role of the intraocular structures and compartments in maintaining normal ocular function. The anterior chamber comprises the aqueous-filled space bounded anteriorly by the cornea and posteriorly by the iris and the lens. Posterior to the iris is the ciliary body. These two structures together make up the anterior uveal tract. The ciliary body has the mechanical role of anchoring the zonules that hold the lens in place. It is also involved in the production of aqueous. The bulk of aqueous drainage occurs via the pectinate ligament and structures in the iridocorneal angle. This is crucial for maintenance of intraocular pressure. The aqueous is normally clear, being free of cells and large molecules, including proteins. This physiological state is maintained by the blood aqueous barrier, which is formed by the vasculature of the iris and ciliary body, as well as the ciliary epithelium. Together with the blood-retinal barrier, this makes up the so-called blood-ocular barrier. The delicate balance that exists within the eye can be disrupted by a number of disease processes. The resulting clinical presentation reflects the impact of disease on the intraocular environment. For thorough inspection of the anterior chamber, the eye needs to be illuminated from different directions and the chamber viewed from different angles. Looking from the side allows assessment of chamber depth. Abnormalities of the anterior chamber can be divided broadly into two categories: abnormal chamber contents and abnormal chamber depth. Abnormal contents include cells and large molecules, space-occupying lesions such as tumours, foreign bodies, and an anteriorly luxated lens. Causes of altered chamber depth include corneal perforation, space-occupying lesions, altered iris thickness, and altered lens size and position. Note that these changes can occur in combination. Cells and large molecules enter the anterior chamber as a result of breakdown of the blood aqueous barrier. This occurs with inflammation of the anterior uveal tract, or anterior uveitis. Clinically, uveitis can present in different ways, depending on the severity of inflammation and the underlying etiology. Inflammatory cells adhering to the back of the cornea form grey patches known as keratic precipitates. Accumulation of inflammatory cells within the anterior chamber is known as hypopyon. Note that the cells often settle ventrally. In this case, uveitis was secondary to an infected corneal ulcer. Plasma protein in the anterior chamber can produce an optical effect known as aqueous flare. While this is frequently a feature of uveitis, a highly focused light source, such as the slit lamp biomicroscope, is often needed to detect it. Note that here again, uveitis resulted from corneal ulceration. A fibrin clot is a more obvious sign of protein in the anterior chamber. Hypopyon and keratic precipitates are also evident in this case. Lipid may also be seen in the anterior chamber, creating a turbidity that can be confused with aqueous flare. Affected animals may have systemic hyperlipoproteinemia. The presence of blood in the anterior chamber is known as hyphema. Again, the blood cells often settle ventrally. If hyphema is extensive, the inside of the eye cannot be visualized. Ocular imaging is indicated and referral should be considered, bearing in mind that there may be extensive intraocular changes. In this case, ultrasound revealed a mass in the posterior globe. This was suspected to be a metastasis originating from a primary splenic hemangiosarcoma. When examining the iris, both its general appearance and surface detail should be noted. Generally, more detail is visible in cats because the iris is usually light in colour compared with the dark brown of most dogs. Thickening of the iris with loss of detail can result from inflammation or neoplasia. In this eye, other changes include iris hyperemia, patches of iris discoloration, keratic precipitates, and a fibrin clot. The diagnosis in this case was lymphoma, mimicking uveitis. Note that lymphoma is the most common secondary tumour to involve the eyes of cats and dogs. In this case of uveitis, iris hyperemia and miosis are the dominant signs of inflammation. As inflammation becomes chronic, the iris may become darker and dull. In this eye, chronic uveitis has resulted in posterior synechia, where the iris adheres to the anterior surface of the lens. In this case, posterior synechia resulted from uveitis induced by leakage of proteins from a hypermature cataract. Anterior synechia are adhesions between the iris and the cornea. These are commonly a consequence of penetrating corneal injuries. Note the distortion of the pupil. Other iris changes include iris atrophy and iridociliary cysts. Again, note the pupillary distortion. The side view shows the cysts bulging into the anterior chamber. Pigment deposition may also be encountered in the iris. It can be localized or diffuse. Pigmented iris lesions can take the form of iris melanosis, in which there is a concentration of normal melanocytes, or iris melanoma, where there is proliferation of abnormal cells. Melanoma generally causes thickening of the iris, giving it a velvety appearance. Iris melanoma is the most common primary intraocular tumour in cats and dogs. In cats, it has a significant rate of metastasis. As the disease progresses, the rate of metastasis increases, so early detection is important. Clinically, iris melanosis can be difficult to distinguish from melanoma, particularly as melanosis can transform into neoplastic disease. Here, some normal iris architecture is still visible, so melanosis is more likely. However, there are some spots in the pupil which may be melanocytes shed from the surface of the iris. This could be an early sign of disease progression. If there is doubt as to the stage of disease, a slit beam is useful for more detailed examination of the iris and anterior chamber. Also, in both cats and dogs, iris melanoma can involve the iridocorneal angle, predisposing to glaucoma. Therefore, investigation of pigmented iris lesions ideally includes gonioscopy to visualize the drainage angle and tonometry to measure intraocular pressure. The lens can be difficult to examine with the naked eye, but obvious changes should be noted. Anterior lens luxation is usually readily detectable, but may be more obvious when the eye is viewed obliquely. Partial or subluxation appears as an aphakic or lens-free crescent between the pupil margin and the lens. Cataracts can present in different ways, depending on their stage of development. Cataracts can be difficult to distinguish from nuclear sclerosis. Nevertheless, this is a very important distinction to make. While nuclear sclerosis is an age-related change that has little effect on vision, cataracts can cause significant visual deficits, as well as secondary problems such as uveitis and retinal detachment. If owners are interested in surgical cataract removal, it is advisable to refer cases early while preoperative assessment of the retina can still be performed using ophthalmoscopy. Surgical outcomes are also better when cataracts are removed in their early stages. Early cataracts can be easily identified using a procedure known as distant direct ophthalmoscopy, which is ideally performed as part of routine ophthalmoscopic examination. This 10-year-old cat first presented with a luxated lens, which has since become cataractus. Distant examination reveals bilateral third eyelid protrusion and mild blepharospasm, suggesting general ocular discomfort. There is also redness in the left eye. On close inspection of the left eye, there is redness in the conjunctiva and also in the iris. Under illumination, deep corneal vascularization is apparent. The right eye shows little redness. However, small grey spots in the iris and changes in the lens are consistent with past inflammation. These findings are suggestive of chronic uveitis. This type of presentation is not unusual. Clinical signs of uveitis are often less marked in cats than in dogs, and the disease may go unnoticed until a more obvious secondary change occurs. Both lens luxation and cataracts are rarely seen as primary diseases in cats, but are relatively common sequelae of feline uveitis. Chronic uveitis is an important cause of secondary glaucoma in cats, so tonometry is indicated for monitoring of intraocular pressure. As feline uveitis is often associated with systemic viral infection, serology may also be informative. This cat was seropositive for feline immunodeficiency virus. The pupillary light reflex is tested by directing a light source briskly towards the eye. The normal response is constriction of both pupils. Constriction in the stimulated eye is the direct response, while constriction in the other eye is the indirect or consensual response. The afferent arm of the pupillary light reflex is the optic nerve. The efferent arm is the oculomotor nerve, cranial nerve 3, which innervates the muscles of the iris. The consensual pupillary light reflex occurs because of crossover of nerve fibres within the reflex path. The so-called swinging light test is a practical aid for checking both the direct and consensual pupillary light reflex. This involves stimulating one eye and observing the direct response, then swinging the light across to the fellow eye. When the light strikes the fellow eye, the pupil should already be constricted and remain that way until the light is removed. Note that both eyes should always be tested for the direct and consensual response so that the results can be compared. It's important to be aware that the presence of the pupillary light reflex does not necessarily mean the animal can see. The pupillary light reflex is subcortical, so a lesion in the cerebral cortex can cause blindness without affecting the reflex pathway.
It's important to also recognise that you don't need an awful lot of photoreceptors to be stimulated to obtain a pupillary light reflex. In some cases of retinal degeneration, advanced retinal degeneration, the animals can still have a degree of pupillary light reflex.
Also, the pupillary light reflex is not affected by cataracts. This is because cataracts impair vision by scattering light, not by preventing it from reaching the retina. On the other hand, sighted animals can have an abnormal pupillary light reflex, for example if an iris lesion inhibits the motor response. If an animal is anxious, increased circulating adrenaline can dilate the pupils and cause a sluggish reaction. It's therefore very important to interpret the pupillary light reflex in the context of other clinical findings. This 8-year-old Kelpie presented with an uncomfortable right eye with corneal edema, episcleral congestion and a dilated pupil. Stimulation of the affected eye produced neither a direct nor consensual response. Stimulation of the unaffected eye produced a direct response and a partial consensual response, confirming efferent function in both eyes. These findings are consistent with a unilateral afferent lesion. This clinical presentation is strongly suggestive of glaucoma, which was subsequently confirmed by tonometry. This 9-year-old miniature poodle has a hypermature cataract in its left eye. The menace response is somewhat equivocal, though careful observation shows that the dog is blinking between stimuli and is not responding to the visual threat. This is expected in view of the cataract. However, the pupillary light reflex is also suspect. This is not explained by the cataract. In the right eye, the direct pupillary light reflex is normal. When the right eye is stimulated, the left pupil constricts at first, but when the light swings across, the pupil actually dilates. In other words, the left eye is able to respond to an indirect stimulus via the consensual response. However, it is unable to maintain the response under direct stimulation. Instead, the pupil dilates from its previously constricted position. This phenomenon, known as the Marcus gun pupil, is indicative of a unilateral afferent lesion. In this case, ultrasound examination identified the lesion as a retinal tear, a recognised consequence of advanced cataracts. This is a contraindication for cataract surgery, so ultrasound is routinely used in preoperative assessment of cataract patients. The dazzle reflex is tested in a similar way to the pupillary light reflex. However, in this case, the normal response is a blink. The dazzle reflex has a similar afferent path to the pupillary light reflex, but the efferent component is the facial nerve, giving a different motor response. Animals don't always dazzle well, so the results are more subjective than for the pupillary light reflex. Nevertheless, the test can still be informative. For example, if an abnormal pupillary light reflex is caused by an efferent lesion, there may still be a dazzle response. Ophthalmoscopy is an important part of routine ophthalmic examination. Performing this procedure regularly builds confidence and makes it a more rewarding experience. The forms of ophthalmoscopy used most commonly in veterinary practice are direct ophthalmoscopy and indirect ophthalmoscopy. The direct ophthalmoscope has two main uses. In distant direct ophthalmoscopy, it is used to view the tapetal reflection to identify ocular opacities such as cataracts. From a close viewing position, it allows direct, detailed examination of the fundus. Indirect ophthalmoscopy is used to examine the fundus via an image created using a lens. Hence, the fundus is viewed indirectly. Fundic examination is technically challenging, but there is much to be gained from becoming familiar with both the direct and indirect techniques, bearing in mind that each has advantages and limitations.
The direct ophthalmoscope offers you a direct view. You are looking at the fundus itself when you use the direct ophthalmoscope. It gives you a very high magnification of the structures you view, but therefore you need to work quite hard to examine the whole of the fundus. The main advantages of the indirect ophthalmoscope is that you get a much larger field of view, so you can see more of the fundus area in one viewing than is possible with the direct ophthalmoscope. One disadvantage of using the lens is that it is inverting the image both upside down and back to front, and orientation can therefore be a little bit more complex. But once you get used to it, it is very handy to get an overall view of where lesions may be located and how significant they may be, because you'll determine how much of the fundus is involved. The direct ophthalmoscope has a number of features which it is worth familiarising yourself with if you are going to use it. First of all, there's the on-off switch, which is combined with a rheostat so that you can control the intensity of the light emitted, and so as you turn it on you can gradually increase the power and the brightness of the light source. It's important to control the intensity of the light beams, particularly if you've got brand new batteries or a recently charged ophthalmoscope. It is a very bright light, and for any of you who have had an ophthalmic exam, you'll know what it feels like. It's mainly to do with patient comfort. The other things you can change with the ophthalmoscope is the type of beam that is emitted. There's the large white light, and that's by far the most common light source or beam that you'll need. There is the ability to change the type of beam that's emitted by rotating this wheel here. As well as a large circular beam, there will be a variety of smaller beams and various grids. Now, the grids are predominantly for the human world and not particularly relevant to us. All ophthalmoscopes have a little rubber stopper here, which is to go close to your eyebrow. So if you do wear glasses, you need to use the ophthalmoscope without the glasses on and have the ophthalmoscope close to your eye. In addition, you've got a lens carousel which changes the lens that you're looking through. To work out the lens setting that is best suited for you, the easiest way of doing that is to hold the ophthalmoscope close to your eye and then find a line or an area of contrast on a wall and rotate the lens barrow until you get that line in sharp focus, and that will be the setting for you to examine the fundus. So if I can demonstrate for you, if I hold the ophthalmoscope close to my eye and rotate the lens until the line on the wall is sharp, and for me that is about -2 or -3, and it will vary depending on the strength of the glasses that you wear. If you don't wear glasses, then the fundus should be in focus on a setting of 0.
Distant direct ophthalmoscopy is a simple and extremely useful procedure. The room should be dark, but the pupil does not need to be dilated. The lens cartridge is set to +1 or +2 compared to the setting for the fundus, in the case of this examiner to 0. The ophthalmoscope is held close to the examiner's eye and the animal is examined at arm's length. The aim is to locate the tapetal reflection, remembering that the tapetum is in the top half of the fundus. In the normal eye, the tapetal reflection is uninterrupted, with light transmitted evenly through the lens. In contrast, a physical opacity such as a cataract will scatter the reflected light, creating areas of darkness. Here there is also a second opacity caused by a corneal scar. This is how these lesions appear under standard illumination. Nuclear sclerosis shows up on distant direct ophthalmoscopy as a ring outlining the nucleus. Unless there is also an opacity present, the tapetal reflection is otherwise uninterrupted. Distant direct ophthalmoscopy is therefore a quick and reliable means of distinguishing between nuclear sclerosis and cataracts. When a cataract is identified, the distant direct technique is also useful for assessing its stage of development.
If the cataract is quite extensive, then the tapetal reflection will become duller and duller until such time as the cataract is total, in which case you'll get no tapetal reflection, you'll just have a black pupil. And obviously the vision impairment should match the degree of cataract. So you can also use it to assess possible retinal problems. If there is an apparently very little cataract but marked visual impairment, you have to worry about the health of the retina. Okay.
Close direct ophthalmoscopy requires an adequately dilated pupil. It is often possible to make a cursory inspection of the fundus without first dilating the pupil, but if a more detailed examination is indicated, a short-acting mydriatic should be used. Approximately 20 minutes are needed for the pupils to dilate fully. If glasses are worn, they should be removed for this procedure. The lens cartridge should be adjusted to a suitable setting, in the case of this examiner to -2. The ophthalmoscope is placed close to the animal's eye, then the examiner approaches the instrument.
All right.
Alternatively, the examiner can move in from the distant viewing position.
As you come into the animal, you need to be probably 1 or 2 inches away. You really want the fundus to fill your view. You don't want to be getting pupil and eyelids in that image, so that you can concentrate on the fundus. Ideally, you should use your left eye to look at the dog's left eye and your right eye to look at the dog's right eye, on the basis that if the dog's nose and your face get in the way of each other, you won't get a complete exam. If you have a dominant eye, and most people do, for example, I can use both eyes, prefer to use my left. I can use the left eye to look at the dog's right eye. And the technique that you apply then is have the ophthalmoscope in the exact same position, but you need to bring your head in at an angle over the top of the dog's nose. That way you will minimally interfere with your ability to explore the whole fundus and ensure you don't leave areas unexamined. It's not as important in cats purely because their nose doesn't get in the way to the same degree. However, I think it's still worth remembering that cats can bite, and so keeping your face or the ophthalmoscope between your face and the cat's teeth is an advantage as well. So again, your left eye for the cat's left eye is helpful.
Examination is further aided by good restraint of the animal, including support underneath the chin. When the fundus is in view, begin by finding and inspecting the optic nerve head. Then examine the rest of the fundus as systematically as possible.
It's important to have a routine that's going to work for you every time you do an exam. I tend to work from the sort of 12 o'clock position and go in a clockwise direction, looking at each quadrant as I make my way around.
If the animal's eye is very mobile, its movements can be used to navigate the fundus.
Once you've performed a fundus exam from a close direct ophthalmoscopy position, you can utilise the different lenses, the lens carousel once again, to change your point of focus in the eye. So as you go more positive, you will bring that point of focus more anterior in the eye. So generally about +6 or 8 will start bringing the lens into focus. +10 will bring the front of the lens or the iris into focus, and then potentially even the corneal surface about +12, +15. Now the problem when you do that is as you change the lens that you're viewing the eye through, you are changing your point of focus as I said, but you are also losing magnification. So to be honest, by the time you get to the corneal surface, the amount of magnification is limited.
The essential components for indirect ophthalmoscopy are a light source and a suitable lens. Binocular indirect ophthalmoscopes are expensive, but they provide stereopsis and therefore the added benefit of depth perception. A much cheaper alternative is to use a handheld light source. This method does not give stereopsis, but can still provide valuable information. Lenses used for indirect ophthalmoscopy are identified by their diopter value, which describes their refractive power.
I think when you're starting out, the best recommendation would be to get a lens that's easy to use. So quite an easy lens to start out with is the 30 diopter lens. But as you can see here, it's a reasonably small lens. You get a large field of view, but you do lose magnification. Being a smaller lens, the focal distance from the eye is not as great as, for example, a large 15 diopter lens, whereby the focal distance from the eye is greater, and consequently it can be more difficult to stay in the correct plane of focus when you're using them. So I often would recommend a 30 diopter lens as a starting point.
In contrast to direct ophthalmoscopy, glasses should be worn if necessary for the indirect technique. Again, a darkened environment and adequate pupillary dilation are required. With the examiner at arm's length from the animal, the lens is brought into position close to the animal's eye. Note that the lens has a silver ring on one side, and this side should face towards the animal. The position of the lens is critical for obtaining a useful image. The lens should be held between forefinger and thumb, and another finger used to stabilize the hand against the animal's head. The lens should be centered over the pupil and held parallel to the iris. The image of the fundus should appear to fill the lens. If a handheld light source is used, it should be held near the examiner's head, as close as possible to the axis connecting the examiner's eye, the handheld lens, and the animal's pupil. Note that the image is back to front and upside down. Any changes should be noted as they appear, and their location interpreted later. The main features of the fundus, as seen through the ophthalmoscope, are the optic nerve head, the tapetal fundus, the non-tapetal fundus, and the retinal vasculature. The retina covers the tapetal and non-tapetal fundus. The retina consists of a neurosensory component, which contains the photoreceptors, and the retinal pigment epithelium, or RPE. In the tapetal fundus, the RPE is unpigmented, allowing light to reach the tapetum. Underneath the retina is the choroid. This highly vascular layer makes up the posterior component of the uveal tract. There are significant differences between cats and dogs in the appearance of the normal fundus. In cats, the optic nerve head is usually located in the tapetal fundus, while in dogs it can be in the tapetal fundus, the non-tapetal fundus, or at the tapetal margin. In dogs, the optic nerve head is myelinated. It is therefore white or pinkish in colour and variable in size and shape. In cats, the optic nerve head is unmyelinated and is therefore small, circular and grey. In cats, the retinal vasculature is relatively straight and extends into the fundus from the edge of the optic nerve head. In dogs, the retinal vasculature is tortuous and the venules extend from within the optic nerve head. There is also considerable individual variation in normal fundus appearance. For example, in subalbinotic or blue eyes, the tapetum may be absent and the non-tapetal fundus may be non-pigmented. This gives the fundus a reddish appearance, and the choroidal vessels may produce a striped or tigroid effect.
The more animals you look at, the more variation of normal you will see. And so you need to build up a library, if you like, of normals. And if something is different to what you're used to, then you need to try and establish whether that is a genuine variation or whether there is pathology there.
Abnormal ophthalmoscopic findings include altered tapetal reflectivity, changes in pigmentation, vascular abnormalities, hemorrhage, retinal detachment, and changes in the optic nerve head. The appearance of fundus lesions varies with the type and stage of disease and the location of the lesion within the fundus. In this case of toxoplasmosis, there are active inflammatory lesions in the tapetal fundus. They appear as areas of hyporeflectivity because the retina has been thickened by swelling and cellular infiltration. Note that the edges of the lesions are blurry, which is typical of active inflammation. These active inflammatory lesions were caused by a fungal infection. Extensive subretinal cellular infiltration has resulted in areas of focal retinal detachment. Again, note the ill-defined borders. Inactive inflammatory lesions are generally more clearly defined. In this case of nutritional deficiency, there is an area of hyperreflectivity in the tapetal fundus. This was caused by retinal thinning due to chronic inflammation. There is also hyperpigmentation. Here, post-inflammatory lesions in the non-tapetal fundus appear as areas of depigmentation. The surrounding fundus is pigment dilute, which is a normal variation. Interpretation of abnormal ophthalmoscopic findings can be challenging, even to an experienced eye. The primary objective, therefore, is to identify when an abnormality is present, so that it can be interpreted in the context of other clinical findings. This 16-year-old cat presented 8 days earlier with sudden onset blindness. The history included polydipsia and medically controlled hypothyroidism. Both pupils were dilated and unresponsive to light, and the retina was visible through the pupil. Ophthalmoscopy revealed bilateral bullous retinal detachment, with the retina billowing towards the pupil. This clinical presentation was suggestive of systemic hypertension with secondary retinal detachment. Initial blood pressure testing showed a systolic pressure of 195, confirming systemic hypertension. With treatment, this had decreased to 120. The retinas had since reattached and some light sensitivity had returned, though visual function was difficult to interpret. The history of polydipsia suggested associated renal disease in this case. This eye was removed from a 9-month-old kitten due to extensive intraocular inflammation and intractable pain. Histopathology revealed pyogranulomatous inflammation typical of feline infectious peritonitis, or FIP. The other eye was normal on initial presentation, but within days became painful with evidence of anterior uveitis. Note the pupil is dilated here due to the use of a mydriatic. Ophthalmoscopy revealed extensive retinal vasculitis. Note the poorly defined edges of the retinal vessels and perivascular discoloration. Compared with the first eye, these changes represent a more typical clinical presentation of FIP with ocular involvement. Usually both eyes are affected on presentation with asymmetrical changes. In this case, FIP was confirmed using immunohistochemistry. This 7-year-old Cocker Spaniel presented with poor vision and cloudy eyes. The maze test established that vision was worse in dim light. This raised suspicion of progressive retinal atrophy, or PRA, particularly as this is recognised as an inherited disease in this breed. The dog's pupils were dilated under normal light, and the pupillary light reflex was present but incomplete. Distant direct ophthalmoscopy confirmed the presence of cataracts in both eyes. Cataracts are a common secondary finding in PRA and are sometimes mistakenly identified as the cause of abnormal vision. Examination of the fundus revealed tapetal hyperreflectivity and vascular attenuation. These changes are consistent with advanced PRA. In early PRA, or in cases where cataracts are advanced, ophthalmoscopy may not be informative. In such cases, retinal function can be assessed using electroretinography, or ERG, which measures electrical discharges from the retina in response to a light stimulus. This normal ERG reading shows a typical large initial spike of electrical activity. This markedly flattened trace indicates substantial loss of retinal function. Fluorescein is a non-irritant orange dye that turns green on contact with alkaline substances, including saline solution and tears. Fluorescein is repelled by intact corneal epithelium, including areas that have re-epithelialized following ulceration. In contrast, fluorescein binds with and is absorbed by corneal stroma that has been exposed by ulceration. Fluorescein testing is mandatory in cases presenting with ocular pain or inflammation. It is also useful as a routine test for assessment of corneal integrity. When fluorescein is used in strip form, the strip generally needs to be moistened before use. It is then touched to the surface of the eye. Both eyes should be tested and compared. After application, the eyes should be irrigated with sterile saline to remove excess fluorescein. This helps to prevent false positives and does not interfere with fluorescein uptake when an ulcer is present. While fluorescein staining can often be seen under normal white light, the eyes should also be checked with a suitable blue light. This is important for detecting smaller ulcers and facilitates assessment of the lesion. Conversely, when there is no ulceration, the blue light helps to confirm the absence of fluorescein uptake. Fluorescein can provide valuable information about the nature and extent of an ulcer. This subtle corneal lesion was shown using fluorescein to be a small dendritic ulcer, a finding which is pathognomonic for feline herpes virus infection. A desmetocele is a very deep ulcer, in which there is a full thickness stromal defect with exposure of Descemet's membrane. The walls of the ulcer stain with fluorescein, but the base of the ulcer does not. It is crucial that this is not overlooked, as the globe is in imminent danger of perforation. In evaluating corneal ulcers, the depth of the lesion is always a key consideration because of its implications for healing. The deeper the ulcer, the weaker the mechanical support provided by the stroma for the process of reepithelialization. To stabilize the cornea and promote healing, it is sometimes necessary to provide additional support in the form of a soft tissue graft. Generally, if there is doubt as to the severity of a lesion or how it should be managed, early referral for further evaluation is advisable. Fluorescein is a useful tool for initial assessment of nasolacrimal patency. After applying fluorescein, the head should be lowered to encourage passage of the dye. The nostrils are then observed for the presence of fluorescein. If both eyes are tested together, it is important to be alert for the first appearance of fluorescein at the nostril to avoid confusion due to spreading of the dye to the other side of the nose. In non-brachycephalic dogs with normal tear drainage, dye should appear at the nostril within 4 minutes. Note that there can be normal variation in the time it takes for each side to drain.
The main limitation to using fluorescein to assess nasolacrimal duct patency is not all ducts drain at the nose, and particularly in brachycephalic cats and dogs, and 50% of cats in general will have drainage into the mouth, and therefore if you don't see anything at the nose, it doesn't necessarily mean there is no drainage. Firstly, you need to assess both eyes and drainage on both sides. If there is no fluorescein in either nostril, you must be suspicious that it could be draining into the mouth. You can look under the lips, look inside the mouth, see if there is any fluorescein apparent. The next step to pursue if you're not getting that drainage is to flush the ducts, and this is usually done with saline, and you can often do this under local anaesthetic. It's very rare that you need to anaesthetise an animal fully.
Both lacrimal puncta should be cannulated in turn, using gentle probing if necessary to locate the opening of the punctum. Saline is then introduced with gentle sustained pressure. In this case, saline emerges from the nostril. If the duct drains into the mouth, the animal typically reacts by licking or swallowing when the saline reaches the tongue. For measurement of intraocular pressure, the two main instruments used in veterinary practice are the Schiot's tonometer and the toner pen. Normal intraocular pressure in cats and dogs is generally between 10 and 25 millimeters of mercury, though some physiological variation occurs. A sustained increase in intraocular pressure is the defining feature of glaucoma. Some clinical signs of glaucoma, such as redness and corneal edema, can occur with other diseases. These include uveitis, which may be accompanied by a decrease in intraocular pressure. Without a tonometer, diagnosis can be difficult, particularly if corneal edema interferes with intraocular examination. Glaucoma can cause irreversible blindness in less than 24 hours, so prompt diagnosis is vital if there is to be any chance of preserving vision.
Well, the Schiot's tonometer is generally more accessible to the private practitioner on the basis of cost, but it does require maintenance and a bit of practice to get consistent results. We have the basic sort of gauge here. The Schiot's tonometer is an indentation tonometer, and basically the lower the number, the more difficult it is to indent, and therefore the higher the intraocular pressure. So it's inversely related. The next component is the plunger. Which threads into the body of the instrument, and it's locked in place with this screw. Once assembled, you should test that all the moving parts are flowing smoothly. The instrument is tested on the footplate provided, and it's a matter of holding the instrument perpendicular to the footplate, just as you would when you were testing the pressure in an animal's eye. And on several occasions, just ensure that the needle is consistently moving to zero, and that it's moving freely and easily and not sticking. If the needle is not moving smoothly to zero, it could mean that there's interference or debris where the plunger is running, and you will need to take the instrument apart and clean it. The same should be applied at the conclusion of using the instrument, so that it is maintained in a good clean state for future use.
Before the tonometer is used, local anaesthetic is applied to the cornea. To perform the test, the animal's head is held upright and the plunger is applied to the cornea several times, ensuring that the readings are consistently the same. A conversion table provided with the kit is then used to convert the reading on the gauge into a measurement in millimetres of mercury.
Now, if the indentation is not very much, because the eye is so hard, you're going to get a reading less than 3 potentially, and it's not possible to be accurate with the intraocular pressure from the conversion tables with that value. So also provided with the kit are a couple of weights, and you should use those weights, go through the process again, ensure you get consistent results, readdress your conversion tables. Because the increased ability to indent the cornea with the extra weight, you'll get a better idea and a more accurate reflection as to what the intraocular pressure is. To put on the weights, it's just a matter of threading them through over the plunger, and they sit in position thus.
Applanation tonometers, such as the tonopen, measure the amount of force needed to flatten or applanate an area of the cornea. While expensive, they are convenient, accurate, and can be used with the animal's head in a normal position. The result is read off a screen, without the need for conversion.
Once you've got a high index of suspicion for glaucoma, the next question you need to ask yourself is, am I dealing with a primary glaucoma or a secondary glaucoma? Primary glaucoma will mean that both eyes are inherently at risk. There is an inherent inability for the drainage angle to work. It can function for a period before, and we don't know what necessarily the factors are, it gets overwhelmed and collapses, and you get an acute rise in pressure, which is painful and unfortunately rapidly blinding. That is a risk to both eyes, and so having one eye affected or presenting to you, the other eye is at risk, and it's so important to establish those cases, because those eyes that are at risk will benefit from preventative treatment. If you do not use preventative treatment, it's been established that the road to glaucoma is much shorter. The other type of glaucoma that we recognise is so-called secondary glaucoma, and this is where the drainage apparatus is normal, and without any other insult they would not develop glaucoma. So those are eyes you're looking for some other factor, and that could be the lens having jumped out of position, a tumour in the eye, overwhelming inflammation, uveitis. Primary glaucoma is far less common in cats, and more often than not when we come across glaucoma we are generally talking about a secondary glaucoma, and the most common cause of secondary glaucoma in cats is chronic uveitis. So it's very important that, you know, in general practice, if you make that diagnosis of glaucoma, you have to take it to the next step and decide, is it a primary or a secondary glaucoma. For example, if there's a breed that we know is predisposed to glaucoma, for example the Basset Hound, if you have one eye that's got glaucoma, probably even more important than treating that one eye is how are you going to look after the other eye, or confirming that the other eye is at risk, because more often than not you've lost a lot of vision after an attack of glaucoma, and so that dog is now relying on that other eye. But you can't ignore the possibility that it's not a primary glaucoma, and if it's a secondary problem, for example a tumour or some other cause that has impaired the function of the drainage angle, it may not be a problem that the other eye is going to be at risk at. So you need to be able to establish what is the cause in that case, and if you can't establish what the cause is, you need to think about how you can get that answer. And I don't think that that's possible to do without extra diagnostic equipment, and that may or may not be readily available in general practice, and in particular gonioscopy, for example, whereby we assess the drainage angle and the ability of that to function and performance function. So my view to glaucoma is it's a field where general practitioners and specialists should work together.